Hello everyone. So let's discuss rheumatology, and today I'll be mainly talking about rheumatoid arthritis. Question number one. Question number one. What is the prevalence of rheumatoid arthritis in UK? The answer to this question is 1%. Okay, this is a basic question from epidemiology. So let's learn some basic epidemiology about the rheumatoid arthritis. The age of onset is around 30 to 50 years, although it can occur in all the ages. That means you can say it is in the middle age. Female ratio, male is 3:1, that means it is much more in females. And prevalence, I told you, is about 1%. And classically, it is associated with HLA-DR4. It's a very important question. And one more thing, which has a special meaning about which I'll talk later on. HLA-DR4 is especially present when Felty syndrome is there, right? So as of now, the four keywords that you got to remember in this particular slide. One is age, middle age, more in female, 1%, and HLA-DR4. There are four keywords to be remembered in this particular slide. Now one more thing, a point about pathology. Of course, it involves the synovial joints. Okay. Joints, they are the primary site of involvement. But in the joint, there are so many structures. Now again, very important question from pathology. What the main site? It always starts from the synovial membrane. The first site of disease is synovial membrane, and it is this site where the pathology starts. And one of the prime factor which start the pathology is, of course, cytokines. But which cytokine plays a very important role? Answer is TNF alpha. TNF alpha. Now there are two things I told you in this particular slide. One is about TNF alpha and other is about the synovial membrane. So the clinical applied about synovial membrane. So when in some severe cases, when they plan for surgery, the clinical applied, they go for synovectomy. This is a reason because they want to remove the root cause. And regarding the TNF alpha, the clinical applied will be using so many TNF alpha neutralizing drugs. This I'll talk to you in great detail when I take the treatment part. But we definitely have the clinical applied about the 2 points which I mentioned in this particular slide. So the carry home message is one, synovial membrane, and second is TNF alpha. Question number 2. A 47-year-old female with a history of rheumatoid arthritis, underline the word rheumatoid arthritis. Painful and red left eye. Point to be noted. Visual acuity is normal. Fundoscopy is unremarkable. What the most likely cause? First of all, the patient says he has acute red eye. Okay. And it is painful. The answer to this is episcleritis. Well, we do get pain in glaucoma also, but in that, visual acuity is affected. It is normal. Same with anterior uveitis also. The visual acuity is affected. And what about keratoconjunctivitis sicca? In fact, it's the most common eye manifestation of rheumatoid arthritis. But it is not painful. It's not painful. It is dry. So by rule out technique, we are left with these two options, scleritis and episcleritis. In both, the sclera is involved, but the classical question in episcleritis, it is painless. It is painless redness. So after ruling out all, what we are left is scleritis. So scleritis is the red eye occur in RA. It is painful and visual acuity is normal, fundus is normal. So write down, I'll be writing more about this later on, but as of now you can still write down scleritis. The important feature of scleritis, it is painful. Painful red eye, okay, vision normal, fundus examination is normal. They are normal. With this background of important thing that we learned about scleritis, let's learn the clinical feature that you will get. Not only eye, let us see what all the clinical feature we get by which we suspect that we are dealing with rheumatoid arthritis. Morning stiffness is the classical feature of all inflammatory arthritis, and this lasts for more than 1 hour. The stiffness lasts for more than 1 hour. What are the joints which are involved in a case of rheumatoid arthritis? They involve proximal interphalangeal joint, PIP, metacarpopharyngeal joint, wrist joint. That means if I have to show you, so this is the PIP, this is the metacarpopharyngeal joint, this is the wrist joint and elbow joint, knee, ankle and metatarsopharyngeal joint in the feet. But classical question that you can't afford to forget, DIP is not involved. This is a very, very frequently asked question. One joint which is not involved is DIP. That means this DIP is not involved. Okay. So same thing, lovely picture, so that you remember you are getting swelling in the metacarpopharyngeal joint and you are getting swelling in the PIP. And one more classical feature that we get in RA is symmetrical arthritis. You can see these are involved. It's both sides. A young lady about 30-35 years come, she has a symmetrical arthritis. It is a very, very important catch point by which you can really think that you are dealing with rheumatoid arthritis. So this is a very important point, and even this is a very, very important point by which you can clinch the diagnosis that I am dealing with a case of rheumatoid arthritis. Now, cervical joint involvement, this again a very important point. In fact, in the entire vertebra, the only part which is involved is cervical spine. Lumbar spine is never involved. Lumbar spine is never involved. So, low backache is never a feature of rheumatoid arthritis. So, if the patient main complaint is low backache, then you revise and you are making a diagnosis of rheumatoid arthritis, you revise your diagnosis. It is such an important line written in all the books. The low backache is not a feature. Now in the cervical joint is involved, so that is a atlantoaxial subluxation can occur if this joint is involved. And this is especially now the clinical applied. Why it is so important to talk about atlantoaxial joint? Suppose due to any reason the patient of RA is undergoing any surgery and you plan to give general anesthesia. We all know when the general anesthesia is to be given, patient has to be intubated. Okay, patient has to be intubated. For that they hyperextend the neck. So if atlantoaxial joint is involved and if the anesthetic is extending the neck, it can lead to subluxation of the joint. Subluxation of the joint, and that can lead to cord compression. So it is very essential when we are planning for surgery, the second clinical point, that it is very essential that when we are planning a surgery of any surgery of RA and you plan to give general anesthesia, X-ray of cervical spine must be done to rule out any problem of involvement of atlantoaxial joint. So it's it's an important point. Cord compression can occur. These patients are prone to osteoporosis also. Now, a few more things that you should know. There are, because the ultimately joints are involved, they lead to certain type of deformity. There are so many deformity, but the one which is the most important and that virtually diagnostic is ulnar deviation of finger. Okay, ulnar, you can just compare the ulnar deviation of finger, the classical finding. I've given you a normal picture also. This is virtually diagnostic. If you are getting this ulnar deviation of finger without involvement of DIP, you are dealing with rheumatoid arthritis. It's a golden line to remember. Ulnar deviation of finger. Z deformity is the other deformity. Again, a commonly asked question in, okay. And one more thing is swan neck deformity. So friends, you don't forget swan neck deformity, Z deformity, and of course the ulnar deviation of finger is the pathognomic feature. Not only it involves the joint, it involves there are certain extra-articular feature also, other than the joint. Patient may have pleuropulmonary manifestation. Few one you write down, but I'll be talking a little bit more later on. Pleural effusion can occur. What is special thing about the pleural effusion? Very commonly asked question. In this, the sugar value is, glucose value is reduced. Glucose value is reduced in pleural effusion due to rheumatoid arthritis. It's a very frequently asked question. Don't forget. Normally reduced glucose in any effusion is due to bacterial infection. But it is not a bacterial infection, but still you are getting low glucose level, the classical. Interstitial fibrosis can occur, so it lead to a type of restrictive airway disease. It lead to restrictive airway disease. Okay. Kaplan syndrome, a commonly asked question. There is pneumoconiosis plus rheumatoid arthritis and then lung nodules. Okay, right? So pneumoconiosis is any occupation lung disease. Rheumatoid arthritis having lung nodules. So what we noticed that as far as so far we concerned, this the lungs may have, in the pleura there can be effusion, in the parenchyma there can be fibrosis, and there can be nodules in the parenchyma. Cardiac involvement, this can be pericarditis, it can lead to constrictive pericarditis, it can lead to MR, AR and MVP. That means there can be valvular lesion can be there. Valvular, but you have, please note it down, whatever valvular lesion are involved, they are all regurgitant type of valvular lesion is there. Okay, but one very important thing that is seen in RA is ischemic heart disease. It can lead to ischemic heart disease. In fact, RA is a good predisposing factor for ischemic heart disease, just like type 2 diabetes. What we always say in type 2 diabetes, ischemic heart disease is very common. Same thing, it is very common in these patients also. So they are about cardiac manifestation. Neurological manifestation, there can be peripheral neuropathies. It's a very important cause. Cord compression, why it can happen? Because of what? Any fracture of the vertebra. Which part of vertebra? Definitely cervical vertebra. And it can lead to mononeuritis multiplex. This all occur due to vasculitis. Vasculitis involving the nerve, they can lead to mononeuritis multiplex. In fact, rheumatoid arthritis is a very important cause of mononeuritis multiplex. Very important cause. Okay, so I hope you are clear about it. Nerve entrapment, again a very commonly asked question. Various types of nerves can occur. It can lead to carpal tunnel syndrome, and we all know median nerve is involved. So when in your exam, the question will be, the patient has come to us, they have pain and numbness in the distribution like this, 3.5 finger, especially in the lateral side. And there is atrophy of the thinner muscle atrophy. So if you get a question like this, you are dealing with carpal tunnel syndrome. So carpal tunnel syndrome, which nerve involved? Median nerve, which area? 3.5 lateral aspect, and thinner atrophy. Okay. Now, what are the other important causes where we can see carpal tunnel syndrome? Carpal tunnel syndrome we can see in pregnancy. We can also see in hypothyroid. Okay, they can also see in diabetes. They are some of the other causes where we can see carpal tunnel syndrome. One more commonly asked question is regarding tarsal tunnel syndrome. Which nerve? Posterior tibial nerve. Is a very frequently asked. They ask which nerve is involved. Posterior tunnel syndrome is the thing that, and it is compressed against the flexor retinaculum in the ankle joint. But they don't ask you flexor, but this is the classical question, don't forget. So in carpal tunnel syndrome, it was median nerve. Here it is a tarsal tunnel syndrome, is posterior tibial nerve. Eye involvement, very, very important question, favorite topic of the MRCP. Now, it can lead to episcleritis. There's an abrupt onset, painless. This is the painless eye involvement. That abrupt onset, painless eye movement with normal vision, normal fundus. Okay, this is episcleritis, the point I mentioned previously also. You can see redness of the eyes there. But we have other reason is scleritis. Again, you are getting redness in the eye, same. And classical exam question, it is painful. So the difference between episcleritis and scleritis is about pain. Like in our question, it was painless red eye with normal vision. Whenever sclera is involved, the vision and the fundus, they remain normal. So painful is episcleritis, no pain is episcleritis. Conjunctivitis can lead to red eye, but again, no pain. No pain. Okay. Well, in these very advanced cases, sclera even can get melt. So it can become thin, it can rupture. So scleromalacia is rupture of the eyeball. So again, one more important point you got to remember, scleromalacia, even the eyeball can rupture. Felty syndrome is the favorite topic of the MRCP. In these patients, HLA-DR4 is 100% positive. Okay. Well, is RA, splenomegaly, and neutropenia. The neutrophil count is reduced, not the lymphocyte. This point, people do commit mistake on this also. So please write it down. There is a especially low level of neutrophil count. Can't afford to lose this question. Your option A will be leukopenia. Especially they will write leukopenia. That means low so-called lympho. They will talk about low level of lymphocyte count. No, it is low level of neutrophil. There can be vasculitis. Okay, and now come the gold medal question for you. All of you write down the answer. So we have seen so many variety of the clinical features. Now come the gold medal question is this. When do you call a patient of RA to be suffering from malignant rheumatoid arthritis? What are the criteria of labeling any patient as malignant rheumatoid arthritis? Write down the answer, and you must scan the, write down the answer in your copy right now and WhatsApp me later on after the class. Okay. So the answer, I hope, so question is, which organ system is involved when you say the patient has malignant rheumatoid arthritis? Well, the answer is skin involvement. Eye is the most common wrong answer. In skin, due to vascularity, there may be big ulcer due to vascularity, and then we call as malignant rheumatoid arthritis. Eye is not the answer. Sjogren's syndrome, patient can have dry eyes. So if he talk about dry eye, dry mouth, that is Sjogren's syndrome. And in fact, RA is the most common cause of secondary Sjogren's syndrome. And due to this reason only, even the most common eye sign is keratoconjunctivitis. Keratoconjunctivitis. The most common eye sign, dry eyes, dry mouth, and bilateral parotid enlargement is Sjogren's syndrome. Anemia of chronic disease, which is a normocytic, normoclinic, and and in the very advanced stages, there can be microcytic, hypochromic. But this occurs only in very advanced stage, otherwise a normocytic, normoclinic, so-called anemia of chronic disease. AOCD stands for anemia of chronic diseases. Okay, AOCD. Nodules seen in 30 to 40% cases, and they are non-tender. Point to be noted very carefully. You can see nodules are there, but they are non-tender, and especially in the extensor aspect of the bones. Finally, the patient may come with the fever of unknown origin, no fever, and remember, RA may be a cause of fever of unknown origin. With this background, so the answer of this question was episcleritis. Now we are getting one more. Okay, we are getting 35-year-9 lady, history of rheumatoid arthritis, 2-day history of red eye. There is no pain, itch or no pain, no itching, and if pupil are equal, vision is normal, most likely again episcleritis. Keratoconjunctivitis, it leads to dry eyes. Scleritis, it is painful, and glaucoma and uveitis will lead to loss of vision. Okay. Now little bit extra point. Why I included this question? It is similar to question 2, but there are some extra point I want to tell you. So in the eye involvement, now this slide is exclusively for the eye involvement. It's a very favorite question of the MRCP, that's why I included this slide. 25% of the patient have eye problem. RA, huge, 25 is a huge percentage. Keratoconjunctivitis sicca is the most common. If they ask most common keratoconjunctivitis sicca, this can they ask as feeling of sand in the eyes. Dry eyes with feeling of sand like particle in the eye is the classical thing that we get in keratoconjunctivitis sicca. Episcleritis, eyes are red, but they are painless. Scleritis, redness with pain. That again, and corneal ulceration can occur. And keratitis, this especially occurs when the patients develop Sjogren's syndrome. In Sjogren's syndrome, we are well aware that eye become dry, and it's so the keratitis and corneal ulceration, they are secondary to dryness. And now, not only the eye manifestation occur due to disease, there can be manifestation due to treatment also. Iatrogenic, that means treatment induced. Treatment induced type of problem is so-called, now what can? Steroid induced cataract. And we also know very well steroid can even include glaucoma also. So there are all so steroid can lead to cataract and glaucoma. Chloroquine can lead to retinopathy. What the name is Bull's retinopathy. Bull's eye retinopathy. So they are so-called iatrogenic by the treatment. Okay. So I hope you are clear about the answer. You are clear about this slide also. If you want, I can make it stay for. Yeah. Okay. I hope you have written it by now. Then most common ocular manifestation is keratoconjunctivitis sicca. This point we discussed in the previous. This beautiful question, lovely question. 46-year-old female, rheumatoid arthritis, progressive shortness of breath. She's taking methotrexate and ibuprofen, and a spirometry shows FEV1, FAC 45%. And that means the ratio is reduced. Normal ratio is, so what he's talking about, FEV1, FVC ratio. Normal it is more than 80%. And we all know very well that reduced FEV1, FVC is like the way it is only 45%. And this 45% ratio, this indicate obstructive airway disease. So if you look into all the options, okay, let's look into the option what they have. Bronchiolitis obliterans, yes, it is a obstructive airway disease. We are convinced this is the answer. Methotrexate pneumonitis, it is not a obstructive airway disease, not. Pulmonary fibrosis, again, not a obstructive, it is a restrictive airway disease, the point I mentioned to you earlier. Kaplan syndrome has a lung nodules. They don't have obstructive airway disease. Lung cancer is altogether a different entity, neither it is, they don't come into obstructive or restrictive airway disease. So having ruled out all other options, beyond doubt, the best answer of this condition is bronchiolitis obliterans. But one more thing I like to add on. Most of the time, it is a lung fibrosis that occurs in a case of rheumatoid arthritis, which is a restrictive airway disease. The only obstructive airway disease which can occur in a RA is bronchiolitis obliterans. This is ranked number 1 getting question, don't forget. Now we talk about question number 6. 50-year lady, rheumatoid arthritis, which complication most likely to occur in this patient? The answer is ischemic heart disease. What I told you in the discussion also, it is for a ischemic heart disease, it is as dangerous as type 2 diabetes. Okay, like type 2 diabetes. So ischemic heart disease is a big problem in RA. Let's look into other option. Does RA lead to CLL? No way. No way. It's not a cause. Hypertension? No. It can lead to pericarditis. It can lead to valvular lesion. It can lead to pericarditis. It can lead to ischemic heart disease. It can lead to valvular lesion. But definitely it is not a cause of hypertension, rule out. Colorectal cancer is not a problem of RA. Colorectal problem is seen in condition like acromegaly. It is seen in condition like ulcerative colitis. It is seen in causes like Crohn's disease. It is seen in familial adenomatous polyposis. FAP stands for familial adenomatous polyposis. They are the cause of colorectal cancer. RA is not a cause. Type 2 diabetes, RA is not a cause of type 2 diabetes. In fact, usually hyperglycemia is not a feature of RA, but this is definitely a complication. So the answer is ischemic heart disease. Question 7. Which one of the following describe the rheumatoid factors? It is IgM against the FC portion of IgG. This is a universal question. Universal question, anybody who appear for any exam, even in this question will be in MRCP part and MRCP 2 also they will ask this question. It is such an important question. So let's read more about basic concept. Once I tell you, this you will not forget. So it is a IgM antibody against the FC portion of IgG. Let's learn the basic concept. The basic concept, look into this. This is the IgG antibodies. It's immunoglobulin. In this we have two parts. One is this, which is the FC portion. Okay. So now against this FC portion, which is in the violet color, FC portion, body develop antibody which are IgM antibodies. So with this picture in your mind, it is a blueprint should be in your mind that IgG antibody FC portion, and you are getting antibody against the FC portion, so-called IgM antibodies. So they are IgM antibody against the FC portion of the IgG. Okay. So one more question, same, true regarding rheumatoid factor, IgM molecule against the own IgG. Patient has his own IgG and IgM antibodies are there. Okay. So let's look into other options also, right? Since very important question, high titer are not associated with severe disease. Okay. Rose-Waller tests involve aggregation of IgG. 80% of have positive and 50% are RF positive. There are other options are there. Let's look into these options individually. First of all, so we learned about the antibody, they are IgM, they target FC portion. This point is already with you. But not only this, there is one more antibody called anti-CCP antibody. Note it down. So there are two antibodies which are really important in RA. One is rheumatoid factor and another is anti-CCP antibody. Okay. So now these CCP antibody, they make antigen antibody immune complex. So anti-CCP antibody does the problem with the immune activating the complement pathway. Anti-CCP antibody is again a very important question. So it is causing injury to immune complex pathway. Now let's read more about rheumatoid factor. Rheumatoid factor we talked about with the IgM antibody against the FC portion. Now let's more about IgM. This can be there in 5% of the normal population also. Normal population. Okay, normal population. So let's read more about rheumatoid factor. It is positive in 70 to 80% of the patient with RA. Point to be noted very carefully. It is not present in 100% cases. This is a very important point that you got to know. Okay. So one more thing. High titer are associated with severe progressive disease. Point to be noted very carefully. Higher the titer means more the progressive disease. And I told you they are present in other disease also. They are not only. So in Sjogren syndrome, they are 100%. This is a very, very important point. And Felty syndrome, it is 100%. These two things you don't have to forget. That means when you say, and remember, Sjogren syndrome, RA is the most common cause of secondary Sjogren syndrome. And Felty syndrome is a very, very frequently asked question in MRCP 1 and 2. But here, the rheumatoid factor is 100% positive. Point to be noted that overall in rheumatoid arthritis, rheumatoid factor is there in around 70 to 80% cases, not in 100%. But once the patient develop either Sjogren or Felty, it becomes 100%. Endocarditis 50%. SLE 20 to 30%. In the question what they asked you was 80%. It is there, but not in 80, 20 to 30%. Systemic sclerosis again 30%. General population, the point I mentioned in the discussion, 5%. Rarely it may be tuberculosis, hepatitis B, Epstein-Barr virus, leprosy. But they are all rare causes. So friend, in this, these two are the most important thing. And of course, you should remember, and this also again, in rheumatoid arthritis, it is 70 to 80% cases. With this background, now let's come to the question what we are reading. So high titer are not associated with severe disease? No, they are there seen in severe progressive disease. Rose-Waller tests involve agglutination of IgG coated latex? No, they involve IgM. 80% of SLE? No, it is only 20 to 30%. And 50% are positive? No, they are 100% positive. So we have ruled out all other technique also, all the options also. Question number 9. You are getting 64-year lady, rheumatology, OPD, arthritis of the bone hands, X-ray finding, fever, the possibility as compared to other possible causes. Lovely question. He said, what are the other things? Answer is periarticular osteopenia. Let's look into the options. So, whenever we see X-ray, soft tissue swelling is an early erosion is the first finding. Okay, write down. In the very early stages, you get soft tissue swelling and little bit erosion. This is the first finding. To be more precise, soft tissue swelling. Now, initially, joint, it shows little widening. Small joints are involved that we discuss. Which joint? PIP or metacarpopharyngeal joint. Initially, the joint space may be little bit more because effusion is there. And that because the synovial is the site of the disease, the point I told you. In the initial stage, there is some effusion and that leads to widening of the space. Later on, the cartilage is destroyed and that leads to the joint space become narrow, point to be noted. And finally, you get ulnar deviation of finger. This is the diagnostic. They look into the finger. Beautiful X-ray. You have seen the gross image previously, but now the image, the idea of showing you images that it remain in as a print in your mind. So that ulnar deviation of finger is the classical features. Okay. So juxta-articular osteopenia is the earliest X-ray finding. When you take X-ray, I told you one of the earliest is soft tissue swelling, and you can soon find that around the joint there is osteopenia. That means rarity. If you take X-ray, you find that some apenic changes are there. Okay, but this is a classical finding because in osteoarthrosis, sclerosis occur. In osteopenia occur in rheumatoid arthritis. Loss of joint space is seen in both RA and osteoarthrosis. It's a common feature. Okay, so loss of joint space, juxta-articular osteoporosis, soft tissue swelling, and ultimately, in the advanced stages, you get peri-articular erosion and subluxation. Due to this, it leads to joint deformity. Okay, so out of all the point, one thing you should not forget is this. This is the most important line: juxta-articular osteopenia or osteoporosis. And the second keyword which you cannot afford to forget is ulnar deviation of finger. So if I have to advise you to remember only two things: ulnar deviation of finger, which occurs in the very advanced stages, and the early stages is juxta-articular osteoporosis. These two are the golden line to be remembered. Question 10. You are getting a 34-year-old lady, RA, diagnosed 5 years back, and okay, she is a RA patient, well controlled on methotrexate, and now she is planning to become pregnant. So now the thing is, she is well controlled on methotrexate, and now she want to get, just see, she's a 31-year-old lady. Okay, young lady, she want to start the family. What drugs? So we have to see what drugs we give, and which is the safe answer is sulfasalazine. So let's look into this thing. So what the nice guidelines? So RA in pregnancy, nice guidelines. Well, first line, RA is a typically developed in a lady in the reproductive age group, 25, 30, 35 years. And whenever, of course, as per nice guidelines, when the lady conceived, then conception become a big problem, and what to plan. So what are the guidelines? The key point as per nice guidelines. There's something very important to note. Symptom, they tend to improve in pregnancy. Point to be noted. That means God is very kind, symptoms get improved, but they again, so in a minority cases the symptom may get reduced, but they flare up following delivery. Point to be noted. Okay, anyway, but one thing is there, that doesn't mean that pregnancy the patient will totally free of pain, not at all. Little severity will be less. Now sulfasalazine and hydroxychloroquine, they are safe in pregnancy as per nice guidelines. So sulfasalazine, that's why in option when we went for the sulfasalazine is the answer, is safe. Well, something, suppose due to any reason there's some flare up of occurs of pregnancy, then we can add low dose steroids. Low dose, it is not steroid, it is low dose steroid to be noted. You can give a short course of steroid if needed. NSAID should be used up to 32 weeks of pregnancy. After that, this should be withdrawn due to risk of early closure of ductus arteriosus. Point to be noted. So that means if the patient has to be given NSAID, but only up to 32 weeks of pregnancy, not after that. Then regarding TNF alpha blockers, surprisingly, it is again that as per NICE guidelines, initially they thought they are not good, but when they studied this, when NICE guidelines, they say they do not show any significant increase in adverse outcome. Surprisingly, actually this word surprisingly was written in NICE guidelines, but again they also added when this study was done that many of the patients included in the study stopped taking TNF alpha blocker when they found they are pregnant. Additional line of the safe line, they say, But they never said any conclusive to give or not. But one thing is there, it doesn't show any major side effects. But again, nice guideline, when they are making a guideline, they should write clearly, but they have not written. As of now, don't use. Methotrexate is not safe in pregnancy, so they should be stopped 6 months before conception. That means what the nice guidelines say. There's one lady who, of course, more common in ladies, and they want to conceive, especially so they must take an expert opinion before they plan to conceive. But any expert like you, so what you would advise? Stop methotrexate at least 6 months before conception. What you can give? Sulfasalazine can be given. Even leflunomide, which is a immunosuppressive drug, not safe in. It is a immunosuppressive drug. It should not be given. And one more thing, patients should be referred to obstetric anesthetic due to what? Atlantoaxial subluxation. So again, nice guidelines very clearly say that every patient should be seen by not only by the obstetrician, not only by physician, even anesthetist should be seen. This is not known to the most of students. Why? They want to rule out any atlantoaxial joint involvement is there, and that patient should be given general anesthesia or not. That can be done only when the patient has been seen by the anesthetist. So friends, beautiful question, lovely information you got on this question. Well, we got 28-year-old female RA and etanercept injection is giving, okay, because she was not responding to methotrexate and sulfasalazine. Which is the side effect of etanercept? Answer is reactivation of tuberculosis. Well, there are so many. TNF alpha is this is a TNF alpha neutralizing drug. Like there are like infliximab also. So whenever we are giving any TNF alpha neutralizing drug, one of the dangerous side effects is reactivation of tuberculosis. Okay, so that's why when we are planning, at least chest X-ray should be done to rule out any tuberculosis focus is there. So they can reactivate tuberculosis, the dangerous side effect for any TNF alpha neutralizing drug. So let's talk about management. How to manage a case of rheumatoid arthritis as per NICE guidelines. So 2018 NICE guidelines, what they say that whenever we are planning, patient come to you, start adding disease modifying agent as soon as possible. One instruction as per NICE guidelines. Okay. Of course, when we are planning the treatment, we have to look into analgesic aspect, physiotherapy also. There are two things has to be also to be seen. Now you are going to ask me a question, sir, why you are adding analgesia when we are giving DMARD? DMARD, they don't have no analgesic action. No analgesic action. They simply slow down the progression of disease. That means they act like a brake, or a speed breaker to be more precise. When the speed breaker is there, automatically the car speed goes down. They simply reduce the progression of disease, but no analgesic action is there. So that we have to give analgesic also. So that when the patient come to us for the first time, you have to give painkiller and start DMARD immediately and physiotherapy. What are the guidelines for physiotherapy? As per guidelines of NICE, when the patient is having pain in any joint, give rest to that joint. But once the pain has disappeared, then allow the patient to go for physiotherapy. Okay, so two things at the same time. When pain is there, give rest to the joint, whatever joint you may. And when the pain disappears, so that will give the good muscle will become strong. Okay. So friends, they start DMARD therapy and the pain is very severe. You can give a short course of steroid also. Of course, NSAID is going on. Okay. Point to be noted, we are giving NSAID, we are giving DMARD as a monotherapy plus minus short course of steroid is now recommended. Previously, they were saying that dual DMRD therapy should be advocated. So now that was the old nice guideline. The new guidelines is don't give 2 DMARD. We give, if you need, patient is too much of pain, you can add a short course of steroid. Point to be noted, short course of steroid, we could add it in pregnancy also. But it is a short course, don't go for prolonged, short, low dose steroid therapy. So patient come with severe pain, give NSAID, give DMARD, and you can give a short course of steroid therapy also. Now he says, well, you are giving a treatment to the patient. What NICE guidelines say? NICE recommend that how to monitor. How to monitor the patient? If you can go for CRP, C-reactive protein, you can check the level and the level goes down. And disease activity, what we use is DAS28 criteria. So what is DAS? Disease activity score. And there are 28 joints where they monitor. That's why they call as DAS28. Okay, but by and large, in the exam, they talk mainly about the CRP is a very important parameter. But they do talk about DAS28 also. And I'm sure most of you are listening for this for the first time. Well, in between, we are monitoring the patient. This is the patient going on very well. Suddenly there is a flare up of the disease there. What to do? Give steroid therapy. Okay. This can be given or even intramuscular also. So, but again, flare up is steroid therapy. Now, we talked about the acute management. Let's talk about DMARD, disease modifying anti-rheumatic drug. Methotrexate is the most widely used DMARD throughout the world. It is given as an oral tablet, usually once a week. And very, very important, whenever you are putting the patient on methotrexate, that in this LFT should be monitored very carefully, okay? Because, and of course, the CBC, this is not FBC, CBC, complete blood count. Complete blood count and LFT should be monitored very carefully because they can lead to immunosuppression and they can lead to liver dysfunction. So they can lead to immunosuppression, so you have to go by the complete blood count. And since they can lead to liver cirrhosis or they can lead to liver dysfunction, so LFT should be measured very carefully. But otherwise, it's a very good drug. This problem is not a big problem, but do monitor about CBC and liver function tests. Now, other problem of this is pneumonitis. It can lead to pneumonitis, and about this, the even option came in one of the question. The methotrexate pneumonitis is a well-known complication. But okay, so that means if needed, chest X-ray should be done. Now, what are the other drug that we can give is sulfasalazine, hydroxychloroquine. Remember, these two were safe in pregnancy also. Leflunomide is a newer immunosuppressive drug, TNF-alpha drug. Okay. So, now what are the current guidelines? Current guidelines are this. that you start, what guidelines was, start with NSAID and monotherapy with DMARD, and if needed, short course of steroids. Patient not responding. We started with monotherapy or DMARD, but later on patient not responding, then you can go for 2 DMARD also. But later on, not to begin with. Previously, we started in the previous NICE guideline, we started with double DMARD, but now single DMARD. So you are giving 2 DMARD, including one of them is methotrexate, but still patient not responding. Then we can plan to add some extra drug. These are the so-called biologicals. They come to biologicals. They include TNF-alpha drug, and etanercept is one of the most widely used drug. Okay, most widely used drug is etanercept. Is again, it is a human protein, it's a monoclonal antibodies, and they block the TNF-alpha receptor. As I told you, they are all TNF-alpha neutralizing drug. It is given as subcutaneous injection. But it can lead to demyelination. This is a very, very important point that you got to know. So it can produce a picture mimicking like multiple sclerosis. So we are away from, maybe a patient may or may not go away from RA, but she will end up with other problem of multiple sclerosis. And of course, the risk include reactivation of TB is for generalized. This is for any drug which is a TNF-alpha neutralizing drug. So what is the extra point you got to remember? Only this line, nothing else, only this line. And second is 2 DMARD. So in this slide, the 2th point you got to remember that we start plan of using TNF-alpha if there are 2 or more than, despite using 2 DMARD, patient not responding, you think of using any TNF-alpha, and don't forget to do chest X-ray before you start TNF-alpha neutralizing drug. Infliximab is the other drug, monoclonal antibodies. Again, it was one of the earliest TNF-alpha neutralizing drug which was introduced. It is given as intravenous. The previous one was given subcutaneous. Okay, and reactivation of TB is a universal. I don't need to repeat about TNF-alpha neutralizing drug. Adalimumab is again a type of TNF-alpha neutralizing drug given as subcutaneous. You don't need to remember the route of administration. You just have to know the name, that these are the drugs which are TNF-alpha neutralizing drug like infliximab, adalimumab, and etanercept. The additional point that you got to remember of etanercept is demyelination. Rituximab is a newly introduced drug for the treatment of rheumatoid arthritis. It is an anti-CD20 drug. Okay, and it is given 1 gram in intravenous infusion at 2 weeks apart, and infusion reactions are very common, very common. And now come the gold medal question is this. All of you write down the answer. Suppose you plan to give rituximab, wonderful drug. So what important precaution you will take before you start giving rituximab? I give you 30 seconds, write down the answer in your copy. What important precaution you will take before you plan for starting rituximab, or which tests you like to get it done before you plan for rituximab? Write down answer. Well, the answer is, if you give rituximab, always do the liver function test and rule out hepatitis B and hepatitis C, because otherwise it can convert this into fulminant liver failure. So the way we are planning, when we plan to start TNF-alpha neutralizing drug, we always do chest X-ray, here LFT and serology also. Not only LFT, serology also. Rather, LFT is more appropriate for methotrexate. Here, serology is a better answer if the patient has any or B or C, maybe in the subclinical condition, don't give rituximab. Abatacept is a fusion protein, but now it is not recommended by NICE, but you should know it is a fusion protein, but not used. So we got a lot of information about the latest drugs. So we got a 24-year-old lady, intermittent pain in the metacarpopharyngeal joint, soft tissue swelling, reduced loss of joint space is there, rheumatoid factor is positive, and you diagnose a case of RA. Most appropriate management to slow the disease progression. Well, answer is methotrexate and short course of steroids. What he's asking, she has pain, swelling, and we want to slow down the progression of disease. Infliximab, rituximab, they are biologicals. They don't slow down the progression, we learned just now. They are used when the pain is severe, their patient not responding despite giving a 2-DMARD and NSAID. We try this drug, rule out. Diclofenac is a simple analgesic. It will not slow down the progression. Methotrexate is the one drug that really is a disease modifying agent. It's the only one which is going to reduce the progression. But do we need to give infliximab? No. This we give only when we have given 2-DMARD. We don't start, rule out. And finally, in this case, we give out of all the 5 options, we give methotrexate and the pain is severe. We can give a short course of steroid. And later on in this patient, what next? Again the question, what next? Patient settle down. Okay, if an acute pain is there, but even if methotrexate is not fully controlling, then we can add any of the other disease modifying agent. Out of this is the best option. We have ruled out all other options. Okay. Question 13. Which statement is true? Is about conception. Which statement is true? Hydroxychloroquine is considered safe during pregnancy is the right answer. I told you this point. Let's look into other option. TNF-alpha blocker are absolutely contraindicated in pregnancy. I told you even the NICE guidelines say that there is no major side effect. This we can give if needed, but not as a first line treatment. It is not absolutely contraindicated. Point to be noted very carefully. Methotrexate should be continued pregnancy. No way. It should be stopped 6 months before pregnancy as per the NICE guidelines. Okay. NSAID should be avoided in first and second time. No, it should be avoided in the 3rd trimester. Whether it can lead to premature closure of the patent ducted. Patient should be encouraged to conceive as soon as possible. After diagnosis, the minimum risk of complication. No, pregnancy is not going to reduce the increase the complication. It rather reduces the severity of disease. So there is no necessity that you conceive immediately. Nothing. It's not the idea. So we have ruled out all other things, and the final answer is hydroxychloroquine is safe during pregnancy. The straightforward question also, but other option we ruled out nicely. Okay. Question 14. Patient shortness of breath. She had been on long-term therapy and she's a cigarette smoker also. And what we are getting is FEV1 80%. FEV1 80%. That means no obstructive, no restrictive. I hope you are well aware that in obstructive airway disease, restrictive airway disease, FEV1 highly reduce, FVC reduce, highly reduce, FEV1, FVC ratio reduce, increase or normal. So here FEV1 is 80% is normal. So that means the patient doesn't have a obstructive or restrictive airway disease. So we can very well rule out their obstructive airway disease, this will lead to restrictive airway disease. Okay, so all are ruled out. Even transfer factor is a 41%. This is reduced. This happen in methotrexate pneumonitis. Okay, nodules are not a complication of drug. They are the part of Kaplan syndrome. Kaplan syndrome that occurs when the patient has associated pneumoconiosis also. There is no history suggestive of pneumoconiosis. So we have ruled out other, and we ruled out the only thing what left is methotrexate, and methotrexate pneumonitis is a well-known complication which will lead to a picture of normal FEV1 with reduced transfer factor coefficient. This fit into methotrexate pneumonitis. Okay. Question 15. Poor prognostic factor is anti-CCP antibodies. Let's look into what are the factors which are poor prognostic factor. Female have worse poor prognosis as compared to males. I told you male-female ratio, male ratio is 3:1. So female. RA factor positive is again a poor prognostic, and remember in rheumatoid arthritis it is there in around 70% cases, rheumatoid factor. It is not there in 100%. It is 100% in Sjogren syndrome. It is 100% in Felty syndrome, but not in, okay, poor functional status of the presentation, and that what we call as DAS 28 score. They take 28 joint with where we see how much the pain is there. If already very poor, that is a poor prognostic factor. HLA-DR4 is a poor prognostic factor. Early erosion, within 2 years, if the erosions are starting, there is a poor progression is there. Extra-articular feature like nodules, maybe skin nodules, maybe lung nodules, they are again poor prognostic factor. Insidious onset and anti-CCP antibodies point to be noted. In fact, if you look into, if you forget all other, if you look into these two only, the two antibodies, rheumatoid factor or anti-TC antibody, if they are present, they indicate poor prognosis is there. So I hope you got a lot of idea. So anti-CCP antibody is a poor prognostic factor. If you look into the answer is this. What about others? HLA-DR, it is DR4, not DR2. Rapid onset, no, it is a slow onset. Smoking is not a criteria of severe, and female sex is also there, more in female. Oh, now come the confusion. Now come the two right answer. Now which to choose? This, especially I took this question, right? Especially I took this question, the two right answer. The examiner always says choose the most appropriate answer. This is much better, much better. What nice guidelines, if you read again, it is usually seen, what the nice guidelines says, usually it is say that female have bit poor prognosis. But anti-CCP presence is a far better criteria of poor. And one more thing, even suppose the option is, which of the following is a poor prognostic? Anti-CCP positive, but rheumatoid factor negative. Now what they say, option are like this. CCP antibody positive but rheumatoid factor negative. CCP antibody negative but rheumatoid factor positive. Both are positive. then definitely this is the best criteria. Okay, the point to be noted, presence of these two antibodies, they really have documented type of poor presentation is there. So there are two right answers, but choose the most appropriate is anti-CCP antibody. Beautiful question. Okay, which good prognosis? Then now the thing that is easy, rheumatoid factor is negative, is a good prognosis. HDDR is a bad prognosis, and all these we discussed in the previous question. All these we discussed in the previous question, they are all the feature of poor prognosis. Okay, so I hope you learned a lot in this. Thank you very much. God bless all of you.